Hello everyone, in today's class we'll be dealing with the Mycosis fungoides. This is the second part. The epidemiology and the pathogenesis has been discussed in the previous class. In this class we'll be dealing with the clinical features and the clinical variants along with the differentials that should be included. The Sezary syndrome, how is it similar and different to Mycosis fungoides, and what is the diagnostic criteria. So let's start with the clinical features of Mycosis fungoides. This disease has a predilection for elderly, most commonly affecting the 55 to 60 years age group, and it has a bit of predilection of males. 2:1 is the ratio, male to female. The sites, the skin lesions affecting is the classically defined as bathing trunk. It includes the girdles, buttocks, and breast. Bathing trunk is an older term used for swimsuits. So these are the regions that are protected while you are swimming. Alternately, you can also call the photoprotected areas are affected by the Mycosis fungoides. MF starts as a patch, progressing to a plaque, and then may progress to tumor. The last stage is the erythroderma, which I'll be dealing in the next slide. In the patch stage, they just present like a discoloration. It almost resembles lichen planus, but very common is telangiectasias and long-standing history. Another point that arises suspicion of MF is that it is resistant to any treatment given in the past. The patch stage then may progress to the plaque stage. The patch here or even here is developing small elevated regions turning into plaque. This one is the patch and here small is the plaque. So it is hypothesized that maybe the patch progresses into the plaque from one side, or the plaque starts healing from one side and progresses to the other side. So this erythematous area, when you put a dermoscopy, you can easily see the telangiectasias. Now the differential diagnosis for this patch and plaque stage can be any scaly lesion. It might even be dermatitis, psoriasis, lichen planus, or even sometimes it can be confused with tinea infection. Now the lesions may even progress to the tumorous stage. These are aggressive expanding dermal nodules which are initially smooth surfaced, reddish brown, and may ulcerate and get secondarily infected later. Theoretically, it has a predilection for face and flexures, but here we can see it over the chest. It can be confused with B-cell lymphoma, carcinoma cutis, even sarcoidosis, any infections like atypical mycobacterial infection, leprosy, and even leishmaniasis under proper background history. So a case study for you all. This patient presented in the OPD. You all can see he is of elderly age group, about 60 years of age and a male. And whatever lesions he had, when he presented to the OPD, he was covered with his shirt and trousers and we couldn't see any skin lesion. He looked very healthy. But once he removed his shirt and showed us the lesions, he had all kind of lesions, patch, plaque, and even this large tumor over the chest and all over the non-exposed area of the body. So this is a very classic example of MF. The age, the male preponderance, the non-exposed area, and we can see the patch, the plaque, and the tumors all over the body, which is exactly in the bathing trunk fashion, the areas that are covered by a swimsuit. Now moving on to the last stage, that is erythroderma. Here more than 80 to 90% of the body is showing the erythema and exfoliation, and the history is very long, which is recalcitrant to any treatment, and the pruritus is very severe. Here two terms you will come across. The napus sclerae, it means there can be islands of sparing. That means there are islands of skin that are not involved in erythroderma. And the second term is the deck chair sign. Here you see that the flexures of the skin are not involved. So here we can see the uninvolved skin are the folds of the abdomen. When the patient is bent over, then these folds, the spared skin can't be seen. It is derived from the deck chair. These are foldable chairs that are used in the seashore, and the fabric of the chair are having alternating stripes, as we can see in this picture. Now moving on to the clinical variants of Mycosis fungoides. The most common that I have seen and which is seen in the brown skinned people is the hypopigmented variant of Mycosis fungoides. Here the patient presents with ill-defined hypopigmented macules and patches all over the body. A very close differential is the PLC, pityriasis lichenoides chronica. The next variant is the folliculotropic Mycosis fungoides. Here the inflammation is seen around the follicles. It is also called follicular mucinosis or alopecia mucinosa. Most commonly, it involves the scalp and the face. These are grouped follicular papules or acneiform lesions. Hair loss is also seen in these plaques. Eyebrows might be involved. There is a history of severe pruritus, and there can be secondary bacterial infection as well. The third one is the granulomatous slack skin disease. These are usually seen in young adults and involves the flexures like the axilla and the groins. It is slowly progressive and there is localized areas of thick pendulous skin folds. The last variant is the pagetoid reticulosis, also called Weringer-Kollop disease. It is also seen in young adults and involves the acral areas of the body. It usually presents as a solitary, persistent, slowly progressive, scaly, usually psoriasiform plaque or patch. Now let's have a look into the Sezary syndrome. Initially, it was thought to be a progression of Mycosis fungoides, but now it has been given a separate entity of its own. Why and how is it different from MF? In MF, the CD4 memory T cell is skin resident memory T cell, while in Sezary syndrome, it is CD4 T cell, but it is a central memory cell. That is, these cells can shuttle between the skin, the blood, and the lymph nodes. The Sezary syndrome has a very high burden of copy number variation. It's chaotic genome from the start. While in MF, it starts with fewer mutations and slowly accumulates them over decades. Sezary syndrome de novo starts with erythroderma, while MF progresses from patch to plaque to tumorous or and then into erythroderma. If the malignant cells are seen in the peripheral blood in MF, it may be called as leukemic MF rather than Sezary syndrome because the cell of origin in both are different. Now, what are the similarities between them? The pathogenesis, the CCR4 mediated epidermotropism is seen in both. CD7 is negative. The JAK-STAT pathway signaling is has an important role in both. So the treatment is also on similar lines. Now, Sezary syndrome has been defined by a triad historically. The first of the triad is erythroderma. It is very pruritic and recalcitrant to treatment. Second is generalized lymphadenopathy. And third one is you have to demonstrate Sezary cells in the peripheral bloods. So how much Sezary cells should be present to satisfy this criteria? Either the absolute count should be more than 1000 per microliter, or it should be more than 20% of the total lymphocytes in the peripheral blood, or it should be more than equal to 5% of total lymphocytes in the buffy coat of the blood. There should be some evidence of peripheral blood clone, a T cell clone present. So it can be proven by either of the three. First, the CD4 to CD8 ratio is more than 10:1, or there is an aberrant expression of the CD cell markers like CD7 may be negative. And the third one, the T cell receptor gene analysis shows some evidence towards Sezary syndrome. Now this is a representative of how the peripheral blood smear in Sezary syndrome will look. So here are the Sezary cells with cerebriform hyperconvoluted nuclei, and you can compare the size with the normal small lymphocytes. We may even find quite a number of eosinophils due to the high levels of interleukin 4 and 13, which also explains the severe pruritus seen in the syndrome. Now this has brought us to the end of today's class. I've tried to make it very crisp and clear and very understandable. Happy learning for now. Meet you in the next class with diagnosis, staging and treatment. Till then, bye.